Good morning everyone. Myself Dr. Ragbi Patel, Assistant Professor from Faculty of Physiotherapy. So today we learn about shoulder dislocation. In this video, we learn about what is shoulder dislocation, its mechanism of injury, classification of shoulder dislocation, different pathological changes, and how to diagnose shoulder dislocation, then different management techniques, then its complication and the physiotherapy management. So first we start with the introduction. This is the commonest joint in the human body to dislocate. It occurs more commonly in adults and is rare in children. Anterior dislocation is much more common than posterior dislocation. So what is shoulder instability? Head of the humerus is not stable in the glenoid. Patient may present with just pain in the shoulder, may present with an abnormal movement of the head of the humerus. The instability may be in one direction, that is unidirectional, or in more direction, that is bidirectional. If it may be in multiple direction, that is anterior, inferior or posterior, where it is called multidirectional instability, MDI. Now we see mechanism of injury for shoulder dislocation. A fall on an outstretched hand with the shoulder abducted and externally rotated is the most common mechanism of injury for the anterior dislocation. A direct force pushing the humerus head out of the glenoid cavity. A posterior dislocation may result from a direct blow on the front of the shoulder driving the head backward. Posterior dislocation is the consequence of the electric shock or an epileptic from convulsion. This figure shows a person fall on an outstretched hand, causing the head of the humerus to dislocate in the anterior or posterior direction. Next is the classification of shoulder dislocation. It is classified in three types, that is anterior dislocation, posterior dislocation and the inferior dislocation. Anterior dislocation. Head of the humerus comes out of the glenoid cavity and lies anteriorly. It may be further classified into three subtypes depending on the position of the dislocated head. First is preglenoid. The head lies in front of the glenoid. Second is subcoracoid. The head lies below the coracoid process. It is the most common type of dislocation. And third is subclavicular, in which the head lies below the clavicle. The figure shows the three types of anterior dislocation. Next is posterior dislocation. In this injury, the head of the humerus comes to lie posteriorly behind the glenoid. This figure shows the posterior dislocation. When a person hits from the front side, the head of the humerus moves towards posterior side. Third is inferior dislocation. It is the rare type where the head lies in the subglenoid position. Next is the pathological changes. The following pathological changes occur in the commoner anterior dislocation. First is Pankart lesion, second is Hill-Sachs lesion, third is rounding off and fourth is associated injuries. Pankart lesion. This was first described by the Perthes as defect in the anterior part of the glenoid labrum and also the anterior capsule. Dislocation caused stripping of the glenoidal labrum along with the periosteum from the anterior-inferior surface of the glenoid and scapular neck. The head thus comes out to lie in the front of the scapular neck, in the pouch. In several injuries, it may be avulsion of a piece of a bone from the anterior-inferior glenoidal rim called bony Pankart lesion. Next is Hill-Sachs lesion. It is a depression on the humeral head in its posterolateral quadrant, caused by impingement by the anterior edge of the glenoid on the head as it dislocates. This is produced due to the impact of the posterolateral part of the head of the humerus against the sharp anterior margin of the glenoid rim. Third is rounding off. The anterior glenoid rim occurs in chronic cases as the head dislocates repeatedly over it. Fourth is associated injuries like fracture of the greater tuberosity, rotator cuff injury, etc. Next is how to diagnose shoulder dislocation. So, the patient comes with the following complaints. Patient enters the casualty with his shoulder abducted and the elbow supported with the opposite hand. History of fall on an outstretched hand followed by pain and instability to move the shoulder. Then history of similar episodes in the past. On examination, we found that the patient keeps his arm abducted. The normal round counter of the shoulder joint is lost and is become flattened. There are two tests for diagnosis of the shoulder dislocation. First is Dugas test and second is Hamilton ruler test. In the Dugas test, that is inability to touch the opposite shoulder, and second is Hamilton ruler test. Because of the flattening of the shoulder, it is possible to place a ruler on the lateral side of the arm. This touches the acromion and the lateral condyle of the humerus simultaneously. The first figure shows the Dugas test, where patient is asked to bring the one hand to the opposite shoulder, but if the patient is unable to touch the opposite shoulder, he may be having the dislocation of the shoulder. Second image shows the Hamilton ruler test, where the ruler touches the acromion process and the lateral condyle of the humerus simultaneously. So we can say that patient is suffering from dislocation of the shoulder. The X-ray shows the anterior dislocation of shoulder. This view shows the widening of the glenohumeral joint space in the AP view. This image shows the inferior dislocation of shoulder. So, what are the different investigations to diagnose the shoulder dislocation? First is CT plus 3D, that is from which we can examine the bony anatomy. Second is MRI, from which we can identify soft tissue, muscles, rotator cuff tear, album tear. Third is ultrasound. So from that we can identify joint effusion. Next we move towards the treatment. First is conservative treatment. Treatment of acute dislocation is reduction under the sedation or general anesthesia, followed by immobilization of the shoulder in a chest arm bandage for 3 weeks. After the bandage is removed, shoulder exercise are begin. So now we learn different techniques of shoulder dislocation. First is Kocher's maneuver, the most commonly used method. These are different steps to follow for the Kocher's maneuver. First is traction. With the elbow flexed to a right angle, steady traction is applied along with the long axis of the humerus. Followed by external rotation, the arm is rotated externally. Followed by adduction, the arm then externally rotated arm is adducted by the carrying of the elbow across the body towards the midline, and followed by internal rotation. The arm is rotated internally so that the hand falls across the opposite shoulder. To remember this step, we have one shortcut, that is TI. Traction followed by external rotation followed by adduction followed by internal rotation. This image shows the steps for the Kocher's method. Second method is Hippocrates maneuver. In this method, the surgeon applies a firm and steady pull on the semi-abducted arm. He keeps his foot in the axilla against the chest wall. The head of the humerus is levered back into position using the foot as the fulcrum. This image shows the Hippocrates maneuver, where surgeon applies pressure to the axilla of the person with his foot. Third is fracture dislocation, a fracture of the greater tuberosity with an anterior dislocation. Open reduction internal fixation, that is ORIF, for the fracture of greater tuberosity followed by immobilization in the cast for up to 3 to 4 weeks. Next we have complications of shoulder dislocation. The early complications are axillary nerve may be damaged or resulting in paralysis of the deltoid muscle. The diagnosis is confirmed by asking the patient to try to abduct the shoulder. Not able to abduct the shoulder from the patient response. Though shoulder abduction may not be possible because of pain, one can feel the absence of contraction of the deltoid. Second is late complications. The shoulder is the commonest joint to undergo recurrent dislocation. Recurrent dislocation following causes anatomical instability, joint, that is Marfan syndrome, inadequate healing after the first dislocation, and an epileptic patient. Next we have the operative treatment for this shoulder dislocation. First is putti-pat operation. Double breasting of the subscapularis tendon is performed in order to prevent external rotation and adduction, thereby preventing recurrence. Putti-pat is one of the surgical treatment options for anterior shoulder instability. In this procedure, the flexible cord tendon of the subscapularis muscle is cut and then reattached to the head of the upper arm bone, that is humerus. Second, we have Bankart operation. The glenoid labrum and the capsule are reattached to the front of the glenoid rim. This is a technically demanding procedure but has become similar with the use of special fixation devices tools. Third is the Bristow's operation. In this operation, the coracoid process along with its attachment muscle is osteomized at its base and fixed to the lower half of the anterior margin of the glenoid. The muscles attached to the coracoid provide a dynamic anterior support to the head of the humerus. Now we move towards the physiotherapy management. In the initial phase, that is up to 6 weeks, exercise may be initiated 1 to 2 weeks post-operatively. Range of motion is delayed for the longer period of time after a thermally assisted stabilization, a posterior stabilization procedure or repair of a slap lesion or torn bicep tendon. Use of cryotherapy or the cold pack and prescribed of the anti-inflammatory medication for the pain relief. Active range of motion exercises for the cervical spine and shoulder relaxation exercises can be begun. Emphasize on spinal extension and scapular retraction to avoid excessive thoracic kyphosis. Active range of motion exercise for the elbow, forearm, wrist and fingers should be begun. Pendular exercises non-weighted usually for the first 2 weeks post-operatively to prevent further complications. Then self-assisted range of motion, that is wand exercise for the glenohumeral joint initially within protected range as early as 2 weeks or as late as 6 weeks post-operatively. Begin shoulder elevation in the supine position to stabilize the scapula. With the anterior stabilization, gradually progress to near complete range of motion exercise by 6 to 8 weeks, except for external rotation and extension and the horizontal abduction. With the posterior stabilization, progress towards flexion, horizontal adduction and internal rotation cautiously. Use of the operated arm for unresisted, non-weight bearing and light functional activities by 2 to 4 weeks post-operatively. Multiple angle, low intensity isometric, that is muscle setting exercises for the glenohumeral musculature as early as first week or by 3 to 4 weeks. Possible initiation of dynamic exercise against light resistance below shoulder level at 4 to 6 weeks. Emphasize on glenohumeral stabilizers. For the 6 to 12 weeks, continue with the active range of motion exercise, nearly full range of motion exercise by the end of 12 weeks. Gain range of motion in functional activities like daily activities. As stability permits, stretching and mobilization in the position that do not provoke instability must be started. The dynamic exercise, that is concentric and eccentric exercises, initiated or progressed using weights and elastic resistance with emphasis on scapulothoracic and glenohumeral stabilizers. After anterior stabilization, do not initiate dynamic strengthening of the internal rotators from full internal rotation, particularly in the 90 degree of abduction position. After a posterior stabilization, do not initially begin dynamic stabilization exercise for the external rotators from the full internal rotation. Progressive upper extremity weight bearing during strengthening and stabilization exercise. For 12 weeks to 1 year, stretching should continue. Resistance exercise to improve strength and endurance are progressed. Participation in desired work related and sports activities up to 6 months postoperatively. These are the reference. Thank you.